Welcome to the AFib Virtual Education Summit, sponsored by Johns Hopkins University School of Medicine on CardioCare Live. My name is Dr. Robert Giuliano, and you are tuned in to a live session called What Do Updated Guidelines Mean for Your Patients with Atrial Fibrillation? Before we get started, I would like to remind our audience that I will be taking questions throughout the presentation. You can send me your questions through the box on the lower left-hand side of your screen. I'm currently an associate physician in the cardiovascular division at the Brigham and Women's Hospital and associate professor of medicine at Harvard Medical School. I'm a faculty member in the cardiovascular division at Brigham and Women's Hospital and have served as a principal investigator for 8 multi-center clinical trials as part of the TIMI study group. I'd like to get started this afternoon on our talk entitled, What Do Updated Guidelines Mean for Your Patients with Atrial Fibrillation? And begin with the disclosure slide, which includes my research grant support, consultants, and honoraria for CME lectures with a variety of pharmaceutical companies in whom I've done research or other consulting activities. This is an important topic because atrial fibrillation is an epidemic, not only in the U.S., but throughout the world. Looking at recent data from U.S. population, we see that there's a 1 in 4 lifetime risk in men and women over 40 years of age of having atrial fibrillation, such that we think by 2050 that 16 million men and women above the age of 40 years old will have atrial fibrillation. And this incidence is climbing as our population ages. This slide shows you the relationship between the percent of patients with atrial fibrillation in different 5-year bands of age. And you can see that the risk rapidly increases, particularly for those patients age 70 and above, and the increase affects men as well as women. Now, the complications of atrial fibrillation come in 2 varieties, if you will, one being hemodynamic complications, including fatigue, shortness of breath, palpitations, and all of these lead to a limit of the patient's ability to perform usual activities and exercise, and it can also result in congestive heart failure. The other type of complication and common complication of atrial fibrillation are embolic type events, and these include stroke or systemic embolism. Stroke in atrial fibrillation is the most feared of the complications. And we know that patients with atrial fibrillation are at about a 5-fold increased risk of stroke compared to patients without AF. Of course, the risk varies, and this depends on the clinical factors for each patient, and we'll discuss more about different risk prediction schemes in a moment. Embolic strokes from atrial fibrillation have a particularly bad prognosis and are worse than in patients without atrial fibrillation. These strokes can lead to substantial morbidity and mortality, and they have an enormous impact on healthcare costs, estimated at about $16 billion per year in the U.S. Data from the Framingham study shown on this slide show how the incidence of atrial fibrillation not only increases with age, but also the strokes attributed to atrial fibrillation increase with age. In other words, as our population ages, we have more atrial fibrillation, we have more strokes, and we have more strokes that are due to atrial fibrillation. Now, the natural history of atrial fibrillation is one of the challenges that we face as clinicians in managing our patients. In blue on this slide are demonstrated time intervals when patients are in normal sinus rhythm, and this is just a theoretic diagram. And in orange are the bouts of atrial fibrillation. And you can see initially that patients are in sinus rhythm and they may have a brief episode of atrial fibrillation and then revert to sinus rhythm, and this pattern can come and go for quite some time. But ultimately, if you follow patients long enough, most patients will ultimately end up in a permanent or persistent state of atrial fibrillation. And this has caused some controversy and some confusion about how patients should be managed. What is their risk for stroke when they're in the blue or in the orange section, and what are the implications for treatment with anticoagulant and antiplatelet therapy? The episodes which are shown on the left-hand side here, alternating between sinus rhythm and atrial fibrillation, are termed paroxysmal. In other words, these episodes are self-terminating. Persistent atrial fibrillation is defined as those bouts that last greater than 7 days, and then permanent atrial fibrillation is defined as patients who have failed cardioversion or are in atrial fibrillation for a year or longer. Now, one of the most interesting and important new findings in the field relates to the incidence of subclinical atrial fibrillation and the risk of stroke. In a paper this January in the New England Journal from the ASSERT trial, investigators looked at the incidence of subclinical atrial fibrillation in patients aged 65 or greater who were having pacemakers or defibrillators placed. Now, none of these patients had known atrial fibrillation at the time of the placement of the device. And yet what they found, investigators followed these patients and found that in the first 3 months, about 10% of the patients were having episodes of atrial fibrillation. And in fact, those patients who had atrial tachyarrhythmias were much more likely to have a stroke event than those who did not have any of these subclinical atrial tachyarrhythmias, and the risk was about 2.5-fold higher. And so this bespeaks this increased risk of patients in atrial fibrillation who often in the early stages may have subclinical disease and or disease that is only paroxysmal, and so they may be either unaware or have only a limited awareness of being in and out of atrial fibrillation. And yet the stroke risk is 2.5-fold increase. So what are some of our treatment options? Well, vitamin K antagonists are extremely effective. Warfarin is the most widely studied vitamin K antagonist for atrial fibrillation. And this meta-analysis from 2007 shows that the risk of stroke can be reduced by about 64% when you pool all the data compared to placebo. Also effective is antiplatelet therapy, and in the same meta-analysis by Hart, warfarin was demonstrated to be more effective than antiplatelet therapy. Now, most of these studies looked at aspirin as the antiplatelet agent, but it didn't seem to matter which antiplatelet drug was studied. Overall, warfarin beats aspirin in atrial fibrillation with a risk reduction of warfarin compared to aspirin of around 40%. In other words, antiplatelet therapy is about half of as effective as warfarin. Well, some patients are at low risk for stroke, others moderate, some are high, and maybe sometimes it would make sense to administer an antiplatelet agent if the risk of stroke was particularly low. So a number of risk schemes have been developed to risk stratify patients with atrial fibrillation, and the most widely used is called the CHADS-2 risk score. This has been around for over a decade, and it's a very simple algorithm where you get 1 point for congestive heart failure, that's the C in CHADS, 1 point for hypertension, that's the H, 1 point for age 75 or greater, 1 point for diabetes mellitus, and the S2 stands for 2 points for stroke or TIA. And you simply add up this score. A maximum score would be 6, and on the right-hand part of the slide, you can see that the incidence of stroke increases as you move up the CHADS risk score. In deciding which patients deserve or ought to be treated with anticoagulation, a threshold has been drawn between a CHADS risk score of 1 and 2, where it was determined or felt by several prominent experts in the field and ultimately those who write the AF guidelines that it would be reasonable to recommend anticoagulation for patients who had a greater than 3% annual risk of stroke. And so this really breakpoint occurred between a CHADS-2 risk score of 1 versus 2. And in general, patients with CHADS risk score of 2 and above are recommended to be treated with anticoagulation. And here are indeed the prior ACC, AHA, and ES guidelines from the earlier part of this decade, where you can see those with CHADS risk score of 0 were recommended to be treated with aspirin, patients considered at moderate risk, so a CHADS risk score of 1, were recommended either aspirin or warfarin with a target INR of between 2 and 3. And then patients who had CHADS risk score of 2 or above were recommended to be treated with anticoagulation rather than aspirin. And of course, patients with prosthetic valves are amongst the highest risk patients. Their target INR should be 3.0 with a range of between 2.5 and 3.5. Well, since these guidelines were released in the earlier part of the decade, there's been 4 important updates or revisions to the guidelines. In 2010, the European Society of Cardiology revised their entire AF guidelines. In 2011, the ACC-AHA had a focused update on their guidelines to incorporate new data and new therapies that have become available. And just earlier this year, there have been 2 other developments and updates to guidelines. The American Association of Chest Physicians published their 9th guideline on antithrombotic therapy. And also the Canadian guidelines had a focus update in early 2012. And we're going to discuss in the upcoming slides some of the changes and the key changes in these 4 new guidelines or guideline updates. So while the CHADS-2 risk score was effective in risk stratifying patients, one of the things that became apparent is that about half the patients, 40 to 50%, were considered to be low risk with a CHADS score of 0 to 1, while 50 to 60% were estimated to be moderate to high risk, CHADS risk score of 2 or greater. But this meant that about half, or 40%, were not receiving anticoagulation, and we knew that anticoagulants are very effective to prevent stroke. And one wondered whether this was a right policy for nearly half of our patients to not recommend an anticoagulant. So efforts largely led by European investigators were undertaken to refine the risk score. And so starting largely in Europe but now being adopted elsewhere, a new type of more precise risk score called the CHADS-2 VAS score was developed. And in particular, this more refined risk score looked to better stratify patients at the lower end of the risk scale. Now, on the left-hand side, you'll see how this risk score is constructed and calculated. You still have the 1 point for CHF and hypertension, but now there's an A2 in the CHADS VAS score, where age 75 or above gives you 2 points. Diabetes is still 1 point. You have the S2 for 2 points for stroke or TIA, with a refinement of any other non-cerebral embolism also counting as 2 points. And then the additional risk scores or risk factors in this refined score include vascular disease, that's the V, that's 1 point. Another A for age 64 to 74 gets you 1 point. And then the S, S with a little c, stands for sex category. In other words, women got 1 point because they're at higher risk for stroke if they have atrial fibrillation compared to men. So now this score ranges from 0 to 9, and in particular, as you see on the right-hand side of this slide, there's a further refinement of the risk at the low end. In parallel with the refinement of scores for predicting ischemic risk, there's also been development of a number of scores to predict bleeding, because clearly, while we want to protect our patients from thromboembolic stroke, we also want to avoid bleeding if at all possible. And one of the latest scores that has been developed that's rather simple to use is called the HAS-BLED score, and this is being increasingly incorporated in the updated guidelines. HAS-BLED, as you can see on the left, stands for the following. The H is for hypertension, that's 1 point. A is for abnormal liver or renal function, depending whether one or both are abnormal, it's 1 or 2 points. The S is stroke. B is bleeding. L is a labile INR. E is for elderly, meaning age above 65. And D for drugs or alcohol, again, 1 or 2 points, depending on how many of those apply, with a maximum score of 9. And you can see that the HAS-BLED score is very effective in risk stratifying patients and has been now incorporated in the European guidelines as a recommended risk calculator, if you will, to help guide therapy. Earlier this year in Circulation, a very interesting analysis was published that incorporated both the CHADS 2 VASC score and the Hasbled score to look at of the use of these two combined scores on the endpoints of all-cause mortality, ischemic stroke, and intracranial hemorrhage. And what you see on this slide are 4 different graphs, and these correspond to patients who are at low risk for intracranial bleeding in the bottom left, and low risk for embolic stroke. So that's the bottom left-hand graph. And then as we move up from bottom to top, that's increasing risk of intracranial bleeding as we go to a higher Hasbled score. And as you move from left to right on these graphs, we're moving at an increased risk of embolic stroke, going from a CHADS VASC score of 0 to 2 on the left compared to 3 and above on the right. So the bottom left is low on both risk scores. The top right would be patients at high risk for on both of these scales. Top left would be low risk for ischemic stroke but high risk for bleeding, and the bottom right are patients who are at high risk for ischemic stroke and low risk for bleeding. Now, one of the interesting things from this analysis that was published is that in every one of these 4 scenarios, the patients did better with oral anticoagulation compared to no oral anticoagulation with this endpoint of all-cause mortality, ischemic stroke, and ICH. However, the magnitude of the difference and the magnitude of the benefit of oral anticoagulation over no oral anticoagulation was greatest in those patients who had high risk for embolic stroke, as shown in the bottom right. So this is one way that you can incorporate these 2 risk schemes that look at both ischemic risk and bleeding risk in your practice with your patients. Now, the recent guideline updates have incorporated this notion of a refined estimate for ischemic and embolic stroke with use and support for the CHADS 2 VASC score. And the implication is that now more patients will be recommended for oral anticoagulation. As shown on this slide, the inner circle is the breakdown of patients who would qualify for or be recommended for oral anticoagulation if we use just the CHADS, the old CHADS 2 score. In red are those recommended for oral anticoagulation. In yellow, where aspirin could be used, or oral anticoagulation. In green, where aspirin alone was recommended. And that's you see in the inner circle. And then in the outer circle is how these same patients now would be recommended for therapy based on the CHADS 2 VASC score. And here you can see that the red portion of the circle is much larger. In other words, by implementing the CHADS 2 VASC score, you'll have more patients who are eligible or recommended to receive oral anticoagulation, while the proportion on oral antiplatelet therapy is shrinking. One of the other important new areas of update in these 4 guideline updates I mentioned deals with the novel oral anticoagulants. And this is a very important and exciting area of development in the field. To date, there are 2 new novel oral anticoagulants that are available for use in the United States. These include dabigatran in the far left, which is a direct thrombin inhibitor or factor IIa inhibitor, and rivaroxaban, which is in the column number 3 there, which is an oral factor Xa inhibitor. There are a number of other novel agents that have been studied, and the FDA is currently reviewing apixaban, also an oral factor Xa inhibitor that was studied in patients with atrial fibrillation in the Aristotle trial and the Averroes trial. And then at the far right, you see 2 other agents that are currently in phase 3 testing, edoxaban and betrixaban. So hopefully we'll have a wide selection of novel oral agents and options to replace warfarin. These different novel agents have some important differences in their properties. I've summarized these on the slide. I'm not going to go through it in detail, but I just want to point out a few key things. So dabigatran is a direct thrombin inhibitor that inhibits factor 2A, while the other 4 are all 10A inhibitors. They all have rapid onset of action generally in 2 to 3 hours. There's a difference in the rate of metabolism by the cytochrome P450 system, so some of these drugs will have drug-drug interactions with other CYP3A4 potent inhibitors. The bioavailability of these agents is variable, with the lowest bioavailability with dabigatran, whereas some of the 10A inhibitors have quite high bioavailability, as high as 80% with rivaroxaban. And with dabigatran, bioavailability has been improved by formulating it with tartaric acid, which helps increase the GI uptake. Most of these novel agents are also transported by the P-glycoprotein system, so there are some important interactions with strong PGP inhibitors that you need to be aware of, and examples of strong PGP inhibitors would be verapamil and quinidine, and so you do want to review carefully the prescribing information for any of these new agents to see which drugs you need to be cautious or dose adjust or avoid when prescribing one of the novel agents. Protein binding also varies across the novel agents, the implication there being drugs that are very highly protein bound, such as rivaroxaban, would not be easily dialyzable, and dabigatran, which has only 35% protein binding, one would predict would be dialyzable. The half-lives of these drugs range from a low of 8 to 10 hours with edoxaban, as long as 20 hours with betrixaban, and so this has implications for when the drug is effective and achieving full anticoagulation, and also implications on whether drugs could be given once or twice a day. That's a very interesting and controversial area. You see the renal elimination also varies up to 80% with dabigatran, and that's why measurement of creatinine clearance is important for dosing some of these medications, whereas betrixaban has very little renal elimination, and one would anticipate a lesser need for dose adjustment in patients with renal insufficiency there. So very exciting time, because we have these very interesting and new and potent drugs now available to us as alternatives to warfarin. Now this slide summarizes one of the key issues with warfarin. Of course, we're all aware as clinicians of the complaints that patients have, and also that we as clinicians experience with the vitamin K antagonists. They're challenged to use. There's many drug-drug interactions. There's food-drug interactions. You need to have frequent monitoring to be sure patients are in range, etc. But another issue with warfarin, of course, is that if we shoot too low in the target INR range, and particularly in INRs below 1.8, you see a rapid increase in the risk of ischemic stroke. On the other hand, if you achieve a high INR, and generally above 3, but particularly INRs above 4, those are associated with an increased risk of intracranial bleeding. So there's a rather narrow therapeutic index we're working with warfarin, and that's one of the nice advantages of these newer agents, which do not have the same narrow therapeutic index, and for the most part there is a single or perhaps 2 doses that need to be used in order to achieve a therapeutic anticoagulation for the vast majority of patients who would be eligible for a novel agent. This slide summarizes the problem with being out of range while on warfarin. This analysis comes from the ACTIVE-W trial, which compared warfarin with dual antiplatelet therapy, aspirin plus clopidogrel, in patients with atrial fibrillation. On the left-hand side, you see patients who achieved a time in therapeutic range of less than 65%. And actually, this analysis is stratified by the centers, by the hospitals. So amongst hospitals whose average time in therapeutic range was not so good, less than 65%, in other words, the control of warfarin was suboptimal, aspirin and clopidogrel were about as effective as an oral anticoagulant. On the other hand, if you had very good control of the therapeutic range, a TTR of 65% or above at the center, and we compare the outcomes in those hospitals that achieve good warfarin control, you can see clearly the oral anticoagulant superior to aspirin plus clopidogrel. This becomes one of the major challenges for warfarin in clinical practice, and looking at large registry data. Perhaps one of the best studies from the US comes from a VA study where the time in therapeutic range was only in the mid-50s. And at any individual hospital, and you may want to look at your hospital to see if they have an anticoagulation clinic and what kind of TTR they're achieving, you'll see that it's often difficult to achieve a TTR in the mid-60s. Well, that's one of the nice things about the oral anticoagulants. We don't have to worry so much about achieving a target level of anticoagulation because the pharmacokinetics are so predictable. And I think that's one of the reasons why these 3 large trials comparing novel agents to warfarin showed better results with the novel agents. What I've summarized here are the 3 large trials, phase 3 trials in atrial fibrillation with dabigatran, that study was called RELY, with rivaroxaban in the ROCKET-AF trial, and with apixaban in the Aristotle trial. And I've used a kind of stoplight color schema here to show in green different endpoints or events where the novel agent was superior to warfarin. All these were novel agent versus warfarin. In yellow, where results were similar. And there's no case here where results were worse with a novel oral anticoagulant compared to warfarin. So if you look at that first row, the primary endpoint, stroke plus systemic embolic events, was either non-inferior or superior with the novel agents compared to warfarin. So 150 milligrams BID of dabigatran was superior to warfarin in the RELY trial. Rivaroxaban in the on-treatment cohort analysis was superior to warfarin. And Aristotle, apixaban was superior to warfarin. Across the board with all 3 of these novel agents, the novel agents were safer with respect to intracranial bleeding. There was less intracranial bleeding with the novel agents compared to warfarin. Overall bleeding was mostly similar in some cases, such as the low-dose dabigatran, or with apixaban there was slightly less bleeding with the novel agents compared to warfarin. Mortality overall tended to be similar or slightly better with the novel agents. Notably, in the Aristotle trial, apixaban was shown to be statistically superior with a p-value just under 0.05 compared to warfarin. Ischemic stroke was similar between the novel agents and warfarin, the exception being the 150 milligram BID dose of dabigatran in RELY was actually better than warfarin at reducing ischemic stroke. And just for your reference, I put the mean time in therapeutic range along the bottom for these 3 trials, and you see that none of them achieved the 65% threshold that was demonstrated in the active W analysis required to show that warfarin was better than dual antiplatelet therapy. So that raises a question, maybe if had warfarin been even better controlled, would these results been different? Now the guidelines have all incorporated the latest guideline updates, these newer agents. And just for an example, because I don't have the time to go through all 4 guidelines, I picked a 2011 ACC-AHA Heart Rhythm Society AF-focused update. And their recommendation is a new recommendation, is a Class 1 indication for dabigatran, and it states that dabigatran is useful as an alternative to warfarin for the prevention of stroke and systemic thromboembolism in patients with paroxysmal to permanent AF and stroke risk factors in patients who basically met the trial entry criteria. So no prosthetic valves, no hemodynamically significant valve disease, no severe renal failure defined as a creatinine clearance less than 50, no advanced liver disease. And so this is given now a Class 1B recommendation in the latest guidelines to use dabigatran. It's useful as an alternative to warfarin. One of the interesting subtext stories from the RELY study with dabigatran was an analysis that looked at risk of stroke by the CHADS score. And so here I show a breakout of low-risk patients with CHADS score 0 to 1, patients with CHADS risk score 2, and those are a higher risk, CHADS score 3 and above. And I want to start first on the far right with the dabigatran 150 milligram BID dose. You can see that dabigatran was better than warfarin across the different groupings of the CHADS risk score, whether the patients were low, medium, or high risk. The results were consistent. With the dabigatran 110 milligram dose, remember this dose was found to be non-inferior or similar in results to warfarin, and once again, at patients with CHADS risk score of 0 to 1 or with 2, the results are almost identical to warfarin, and we see a trend towards a benefit in the higher risk patients. So this gives, I think, many of us comfort to recommend dabigatran in patients even who are at the lower end of the risk score. Of course, a major finding, as I mentioned earlier with the novel agents, is this large reduction in intracranial hemorrhage. Intracranial hemorrhage is reduced by more than half with the novel agents compared to warfarin. I think that's a very comforting message and one of the important things that I discuss with my patients when they're trying to decide between a traditional vitamin K antagonist, warfarin, or one of the novel agents. The ESC 2012 guidelines are summarized here, one of the key tables now, and I wanted to bring in two of the important new developments in this guideline. One is the incorporation of the CHADS-2 VASC score, and also you can see on the right-hand side how these guidelines now incorporate the newer oral anticoagulants. So the European guidelines now read that those with CHADS VASC score of 0, because they have a very low stroke rate, well below 1%, no antithrombotic therapy is recommended. Those with a CHADS VASC score of 1, previously felt to be pretty low risk, but now as we learn more about this group, really I would consider more of a moderate risk for stroke, are recommended to be treated with a vitamin K antagonist, targeting an INR of 2.5, or the European guidelines say you may use one of the novel oral agents. Of course, in the US, that would be dabigatran or rivaroxaban. Apixaban not yet available or approved. In those patients with a CHADS VASC of 2 or above, the European guidelines say that either warfarin or one of the novel agents may be used. Well, I am going to speak about the future of guidelines and future findings and directions in this field, but before I go to that, let me take a moment to turn to some questions, because we've had a number of very good questions that have come in, and I encourage you all to use the interactive question and answer so we can have a good discussion about things here. So, first question. Oops. What was the oral anticoagulant used in the earlier studies? These studies predominantly use warfarin in the data that I'm showing in this study. In certain countries around the world, in Europe, other vitamin K antagonists are available. For example, in Spain, acenocumarol is more commonly used. In Germany, fenprocumarin. But it's not clear that there are really major differences in clinical outcomes using one of the other vitamin K antagonists compared to warfarin. One of the early questions, why do women have increased risk of stroke? We showed in the earlier slides. Well, this is a very interesting and controversial issue. Women may have an increased risk of stroke because in general they tend to be older and they have other comorbidities that travel with increased age, including more hypertension, higher rate of diabetes. So there's some of this overlap of risk factors that tend to group with the women, but there are also some independent risk factors. Perhaps it has to do with other disease states that are more common in women, like collagen vascular disease, and yet to be undefined, but women have both a higher risk of stroke when you cut the data looking just comparing women and men, but also when you adjust for the other risk factors that have been identified in stroke. Okay, I have a question here about GI bleeding and what is the risk of GI bleeding with the newer agents. There have been, well, let me answer it in two ways. One, looking at individual trials, it looks like the risk of gastrointestinal bleeding is similar, perhaps slightly higher in the dabigatran versus warfarin comparisons. But with the new agents, I'd say fairly similar risk of GI bleeding. There's a meta-analysis that's also been published looking at new agents versus warfarin, and there the GI bleeding risk looks to be about similar. So a number of meta-analyses coming out, but I think that's an area where we need more study. A related question has to do with H. pylori, and of course, if we could identify patients who are carriers and have active H. pylori infection, then it would be best to treat those to minimize the risk of GI bleeding. So that's a good point, good clinical pearl as you're considering use of anticoagulants. Okay, another question here about a particular patient in a case. An 85-year-old man has non-valvular atrial fibrillation and a past history of intracranial hemorrhage while on Coumadin. Would you recommend one of these new novel anticoagulants? Well, this is a great question and a very challenging one. I would say that it would be difficult to recommend a novel anticoagulation in a patient with a prior intracranial hemorrhage. Recognize that in all of these studies with the novel agents, patients with prior intracranial hemorrhage were excluded. So we really don't have any basis from the trials to discuss, what's the risk of a recurrent ICH with a newer agent. I probably would be very cautious about using ICH. I'd have to know a little bit more about what their risk of stroke and maybe look at the CHADS VASC score. I might feel better about aspirin. I think I need to know more of the details in this particular case to even consider whether I would go with and try warfarin again or not. Was this at a time that the INR was high? But this is a very difficult patient in general. I guess the shorter answer is in patients with prior ICH, in general, I'd stay away from the novel agents. Well, we'll have some more time for questions, I hope, at the end. Let me move on to the next section dealing with the future and some interesting things that are in the works. So one area I want to talk about is biomarkers, because as you look through the CHADS score and the CHADS VASC score, you see there aren't many biomarkers incorporated in these risk scores. And yet we are learning, and these are very interesting data from Malai, where patients who have higher levels of troponin, or as you move up the quartile of NT-proBNP, these patients are at higher risk for stroke, but also at higher risk for vascular death. So I think one of the areas for future study and development is going to be how do we incorporate some of these novel biomarkers we have into risk prediction. In a very interesting analysis here shown on the slide, you see how even when you stratify patients using the CHADS score, you can further refine risk with these biomarkers. So in the upper left, you see patients with various levels of troponin and CHADS score, and it's helpful to know both because you can really get a more accurate assessment of the risk. Even patients who were thought to be at pretty low risk by CHADS score you can see that their risk of stroke, systemic emboli, and other vascular type events increases if their troponin is high. Likewise, in the upper right with NT-proBNP, and then somebody might say, well, are these two biomarkers telling us the same thing? And the answer is no. If you look at the bottom graph, you see that troponin and NT-proBNP both independently give you information about risk prognostication. And then, of course, there's great promise for further information from knowing about specific genetic markers. And I just pulled one specific genetic marker from a sub-study from Rely, where the risk of bleeding was related to a genetic abnormality here, the RS2244613. Was helpful in defining different risks of bleeding. You see there's 4 groups shown on this curve. Carriers of this marker who were treated with dabigatran had the lowest risk of bleeding, that's shown in the red on the y-axis is freedom from bleeding, so higher curves are better here, whereas non-carriers were identified at a higher risk of bleeding. And the interesting thing is that this risk marker had a reverse effect amongst patients who were treated with warfarin, where the carriers had a slightly, in black you see the carriers who received warfarin, and they were very similar in their risk of bleeding to the non-carriers on dabigatran. And in green is the non-carriers on who were treated with warfarin. So going forward, I believe we'll find that other genetic markers will be helpful to incorporate in our risk stratification of patients. Well, that brings me to the summary, and then I do want to leave some time at the end here. We have a number of very interesting questions, and I just have a few take-home messages here. First, remember that atrial fibrillation is a disease state that is becoming increasingly prevalent, both because the underlying risk factors are generally increasing, but also our population is aging, and age is probably one of the most potent risk factors for atrial fibrillation. That we now have some very effective tools to risk stratify patients both with respect to stroke, but also with respect to bleeding. And that these kind of risk stratification schemes can be very helpful to the clinician as they try to decide, which patient deserves what kind of therapy, and which patients maybe need different approach because their risk of bleeding is too high or their risk of stroke is very low. That the recent updated guidelines, of which there are 4 in just the last 2 years, have made a number of new changes, including more frequent support or recommendation for use of anticoagulation in a greater number of patients with atrial fibrillation. They have also incorporated these novel agents, and as you saw from the ACC/AHA Heart Rhythm Society guidelines, as well as the ESC and the Canadian guidelines and the chest physician guidelines, all these guidelines now are recommending use of novel agents in the right patients as they were studied in the clinical trials. I think that looking towards the future, there will obviously be newer and more additional options for oral anticoagulation. We know of several factor Xa inhibitors that are currently in phase 3 study with different pharmacokinetic, pharmacodynamic profiles that will also hopefully be available for use. And we also know of ongoing research to try to refine the risk prediction strategies, including use of biomarkers and genetics that will hopefully guide our management. Well, let me take a few more questions as we have several more minutes left in the program. So important question comes in about reversal of these novel agents. And the question is, have I had any personal experience using protein complex concentrations to help treat bleeding complications of these anticoagulants? No, I have not personally used any of these PCC agents. But what I can tell you is that there are data available both in the preclinical setting, so animal models with factor Xa inhibitors, and there's a very nice but small study in healthy volunteers who received rivaroxaban that showed that PCC is effective to reverse the anticoagulant effect of factor Xa inhibitors. I think that blood products such as PCC are an option for factor Xa inhibitors, although I have to say that they're not yet approved, and this would be an off-label indication. But I think if you're faced with life-threatening bleeding and a patient's received a factor Xa inhibitor, that's one option. It's a little less clear what's the best way to reverse dabigatran, and at the moment there are some individual reports of use of dialysis to reverse dabigatran. But one of the things I would like to point out is these novel agents all have much shorter half-lives than vitamin K antagonists. So one good feature is that they do wear off rather quickly. Okay, and we do have time for more questions, so I recommend, or I encourage you all to send your questions along here in the last 5 minutes or so. So here's a very important question. At what point do you stop anticoagulation therapy in patients with atrial fibrillation? Well, the answer is that you don't, unless they cannot tolerate it or develop a contraindication. The latest guidelines even say that amongst patients who go for AF ablation procedures or for cardioversion and convert the sinus rhythm, that the decision whether to continue anticoagulation or not is based on their risk factors and not on whether they're in sinus rhythm or not at that moment. In other words, restoration of sinus rhythm is not a reason to stop anticoagulation. Look back at their risk profile. If they have a CHADS-2 risk score of 2 or above, or a CHADS-VAS score even 1 or above, the current guidelines would say those patients should be treated with anticoagulation long term, even if they revert back to sinus rhythm. In other words, patients with paroxysmal atrial fibrillation still deserve anticoagulation. And the reason is because these patients are going in and out of atrial fibrillation, even if they've had what we think is a successful procedure, AF ablation or cardioversion or other. So I'm very glad that that question came in, because that's an important one to consider. So another question a little bit off the topic is, are there studies ongoing or have been completed with dabigatran in patients with venothromboembolism? Or is this drug being targeted just for atrial fibrillation? And so I'll answer this one briefly because I'm not the expert on VTE, but yes, there are a number of studies with all of these agents, in fact, not just dabigatran, on the venous side, looking at prevention of DVT and PE in patients undergoing surgery, also looking at the treatment of DVT and PE. So all of these novel oral agents are being studied not only for atrial fibrillation but also on the venous side, and there's some very good data with dabigatran, and I would refer you back to those papers, or the prescribing information for dabigatran can give you the details on that. And also, of course, a good source would be the ACCP, the CHEST guidelines, which talk not only about atrial fibrillation but also talk about other indications for anticoagulation. Okay, let me see. I think we'll have time for maybe 1 or 2 more questions. What is the recommendation on cardioversion after novel anticoagulants in patients with unknown onset of atrial fibrillation? So, great question. I'm glad that this one came in. So the recommendations are to mimic basically what we have been doing for many years with vitamin K antagonists. In other words, if you don't know when the atrial fibrillation started, or you do know and it's been more than 48 hours, these patients should be anticoagulated for 3 weeks, be it with a novel agent or with warfarin, and then undergo cardioversion, and then continue anticoagulation for 4 weeks. And whether you're using a novel agent or a vitamin K antagonist, it doesn't really change those recommendations. It's still 3 weeks before cardiovert and then at least a month afterwards. And then beyond that 4-week time point, go back to the patient's risk and risk stratify them again. If they're at high score on CHADS or CHADS-VAS, those patients ought to continue actually on oral anticoagulation if they're a candidate for long-term oral anticoagulation. Okay. Great question here, and a tricky area. Do you need to adjust the dose of novel oral anticoagulants in patients already receiving aspirin and clopidogrel, for example, a patient who's received a recent stent? So this is an area, honestly, where we need some more study. In these trials, most of the studies had entry criteria that restricted patients to use of aspirin alone, or in some protocols, if you had developed an indication for a second antiplatelet, like you needed an intracoronary stent during the protocol, some of the protocols would allow dual antiplatelet on a background of the novel agent. In some of the protocols, actually, patients had to come off study drug, the novel anticoagulant, if they needed dual antiplatelet drugs. So it's an area where we don't have a lot of data at the moment. The recommendations are to not do any dose adjustment in patients with, requiring dual antiplatelet therapy. But I think this question really is an important one because it's one of the future areas of research. We need to know better what to do with our patients who need both aspirin and a second antiplatelet, and how safe is it to add in a novel agent, and what's the duration of therapy for these various drugs. So great question. Okay, so I have a question here about, would you get anti-10A levels to monitor patients on a novel 10A inhibitor? Well, at the moment, that's not recommended. And there's two real issues here. One is there's not general agreement from amongst the experts or from the manufacturers of what a therapeutic level of anti-10A is, nor is there really a good feeling for which of the various tests that are available to use. These tests are generally available only in special hematology laboratories, so they may not be widely available at your local hospital. And so outside of a research indication or maybe a very unusual clinical circumstance, I wouldn't recommend monitoring 10A levels in patients on novel oral anticoagulants, the 10A inhibitors. Well, I want to thank you very much for your questions. They were very interesting and added quite a bit to this discussion today. And I also want to thank Boehringer Ingelheim for their support of this important educational series. I also would ask you to please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for Dr. Hugh Calkins and Dr. Joseph Marine in a discussion on entitled Atrial Fibrillation, from Pharmacotherapies to Interventional Approaches. Once again, my name is Dr. Robert Giuliano, and I thank you all for joining me.